Walaikum assalam wa rahmatullahi wa barakatuh. Yes.
Okay. So now we are moving to the second part of our lecture. So yesterday we saw some acute problems like ARDS and bronchial asthma. Usually they are like their presentation is acute. Now today we are going to discuss about some chronic airway diseases. So we are going to discuss some chronic airway diseases. So what are these chronic airway diseases? Okay. So our ILO today will be of like to talk about the chronic obstructive pulmonary disease, its epidemiology, burden in the society, and then different types of chronic obstructive pulmonary diseases or chronic obstructive airway diseases. Like the next case of yours is something related to the chronic obstructive pulmonary diseases. So these diseases have a spectrum of diseases. It's not a one disease. It is collection of 3 or 4 diseases together. So what are those diseases? We are going to discuss them in detail, like emphysema, chronic bronchitis, and bronchiectasis. Okay, so as we are going to discuss about the obstructive air diseases where there is obstruction to the airflow. Okay, along with we all we also will look into a few group of diseases which are known as interstitial lung diseases or restrictive lung diseases. There is no obstruction to the flow. The trachea, the bronchi, the bronchioles, and the different section of the respiratory terminal bronchiole, the alveolar duct, they all are working fine in this. Okay, there is fibrosis in the lung parenchyma that will restricting the alveolar space. So that's why you call it as a restrictive lung disease. The other group is obstructive and the another group is restrictive. In the restrictive, there is no obstruction to the airflow. There is restriction in the alveolar space due to fibrosis. Okay, so what do you mean by obstructive pulmonary diseases or obstructive airway diseases? These are group of lung diseases, okay, which are characterized by chronic or recurrent progressive airflow obstruction. Okay, it's very important to know this word progressive. Why it's important? Because there is obstruction today. Suppose obstruction around you see like only 5% obstruction, but as a time progress, this obstruction also progresses and it from 5 it can go to the 50 or 90%. Okay, and these are the group of diseases which come under this one. Okay, emphysema, chronic bronchitis, asthma, and bronchitis. These 4 group diseases grouped together is called a chronic obstructive pulmonary diseases. Out of that, asthma we have already discussed, but in the clinical practice, when you call COPD, we usually mean by emphysema and chronic bronchitis. Okay, but when you have been asked about like how mention the name of the diseases in the chronic obstructive pulmonary diseases, you must mention all these 4 names. Okay, emphysema, chronic bronchitis, bronchial asthma, and bronchiectasis. But when like in the clinical scenario, when you talk, the patient is of COPD, it could be either emphysema or chronic bronchitis. Usually we label bronchial asthma and bronchiectasis as bronchiectasis. We don't call them as a chronic bronchitis. But when we call it is chronic bronchitis in a ward, in a clinical setting, it means either emphysema or chronic bronchitis. So this definition is clear for you all.
Yes, Ajit.
Okay. Yesterday I saw like many students were there in the class, but today I feel the attendance is very poor. So I think my lecture was not good, maybe. Okay, so we move on to what are a brief about this table. This table talk, this is a very good table. Briefly, you will know on your fingertip what are these diseases. Okay, you have chronic bronchitis where it is affected size is bronchus. Okay, it is, what is the major pathological change over here? Here you see the mucus gland hyperplasia and hypersecretion. Okay. And what is the etiology? The principal etiology for the chronic bronchitis is smoking and air pollution. And what are the symptoms over here? Cough and sputum production. Why sputum production? Because there is mucus gland hyperplasia and hypersecretion. Bronchiectasis, again, the site involved is bronchus. Okay. Here what you see in the bronchiectasis, there is dilatation. There is actually, it is obstructive, but why there is a dilatation? Because the lumen is dilated, but there is scarring. The wall has become very thick. The lumen has become tortuous, not like a smooth flowing, like smooth surface lumen. Because of the scarring, there is like somewhere hyperplasia, somewhere like elevated spots. That's why there is obstruction. Okay. And what is the cause for it? It is due to a persistent or severe infection, like upper respiratory tract infection, or sometimes persistent pneumonia can lead to destruction of the small airway, small bronchioles, and it can go up to the bronchi and cause dilatation in the scarring. Here again, you have the cough, sputum. Because there is infection, the sputum will be purulent and there will be fever. Asthma, you know very well, it is also located in the bronchus. Pathogenesis is inflammation, smooth muscle cell hyperplasia, mucus gland hypertrophy. The etiology over here could be atopic or immunological or non-immunological. Where what over here? Wheezing, cough, chest tightness, and dyspnea. The other one is like bronchiolitis, small airway disease, bronchiolitis. This is also a part of chronic obstructive pulmonary disease. This is the major four, but there is also where the small airways are involved. It is due to inflammation, and it is the etiology remains same for over here, like tobacco smoking and air. Okay. Uh, this is cough and dyspnea. Now I forgot to mention about emphysema. Emphysema, we have a sinus where there is the enlargement of the wall, but with that there is destruction. So because of the destruction, there is obstruction of complete airflow. Smoking is the one of the most common etiology for the emphysema, and the major symptom will be breathlessness or dyspnea. Okay, so this is the table, and now here you see about here, this is an sinus. Okay, you are there, you have the terminal bronchiole, and from there start respiratory bronchiole, alveolar duct, and alveolar spaces. This is a sinus. Okay, and this is your trachea, bronchi, and bronchioles. Okay, so in the pure chronic bronchitis, in the pure emphysema, usually rarely you are able to see the pure spectrum. There is always some overlap. Okay, so in the pure chronic bronchitis, you will see the involvement of the large airway. There is inflammation and mucus hypersecretion. In the pure emphysema, there is involvement of the sinus, respiratory bronchiole, alveolar ducts, and alveoli. There is loss of elastic recoil, and this will lead to emphysema. And you see the clinical presentation over here, the chronic bronchitis patient have cyanosis, while the emphysema patient will not have cyanosis. They will be pink in color because of the oxygen is coming in good amount over here. Okay, there is no hypercapnia. Okay, so this is a difference between different type of your chronic obstructive pulmonary diseases, where you have the airflow obstruction. You have like these four are the major diseases: bronchitis, bronchiectasis, asthma, especially the chronic bronchitis, asthma, bronchiectasis, emphysema, and small airway disease, bronchiolitis. Okay. Now, epidemiology. Okay, it is quite a common disease, like 7.6%, almost 8 out of 100 have this kind of disease. If you look at your class, you have 140 boys, so you can imagine out of 140, like you have 8 plus again you add 2 more. Okay, 10 might get affected with the COPD. Okay, in the urban, you have like 10% involvement, and in the rural it is less, because urban, sorry, here should be like according to the area. Okay, so you have like in the urban population 10% incidence, in the rural population 8. Male, it is more common than the female, and in the active smokers, 15%, ex-smoker 10%, and the non-smoker 4%. Non-smoker because of the urbanization and the environmental hazard. In the Saudi Arabia, you see like Saudi Arabia, you have like 14.2% on Saudi smokers. Okay, so it is quite high. Okay, and this study you have from the Annals of Thoracic Medicine, which is published in December 2011. Okay, so the incidence or prevalence of COPD is quite high in Saudi Arabia. Okay, like burden, the global burden. Yes, sir. Initially, like in 2002, it was the fifth leading cause. Okay, but coming 2030, COPD is expected to be the third leading cause. Okay, just imagine third leading cause, how common is going to this problem. Okay, and look at the number, more than 3 million people died in 2012. Okay, and which is equal to 6% of the all deaths, 6% of the all death just due to COPD. Okay, and you see these deaths are more common in the low and middle income group countries, and the primary cause for the COPD is tobacco smoking, whether active or passive. Okay, so see how it has increased gradually from 1980 to 2000, and how the women, just look at the number of ways they have become equally from just around 10% to coming to the 60%. How much increase in the women? Okay, and like women are more risk at a more risk to the environmental hazard, especially the smoking and smoking related diseases. The reason is unknown, but still research is going on to know the exact reason why the women are at a higher risk of this smoking related disease, especially the COPD and the lung cancer. So now we go to the first disease of the chronic obstructive pulmonary disease, that is emphysema. Okay, so definition, as like I told you in the yesterday's class, bronchial asthma definition is clinical and plus pathological. Okay, while the emphysema definition is purely pathological definition. Okay, what happened over here? Irreversible enlargement of the air spaces distal to the terminal bronchiole. Very, very important to know. There is irreversible enlargement of the air spaces distal to this terminal bronchiole. Okay, and this is accompanied by the destruction of their walls without obvious. There is a destruction of the wall, but there is no obvious fibrosis. Okay, everything is pathological. Enlargement of the air spaces distal to the terminal bronchiole, destruction of the wall, but without any obvious fibrosis. So what is the pathological change and what is the reason for the obstruction here? It is due to the destruction of the elastic tissue. There is destruction of the, because if you know physiology very well, the lungs are highly elastic tissue. Okay, there is elastic recoil, the air go, it flow, and then it's constrict like a balloon. So there is this elasticity is lost, and that's why it lead to the obstruction. In a simple definition of emphysema, abnormal and permanent dilatation of alveoli with minimal or with tissue destruction and without obvious fibrosis. This is a simple definition, but remember this word distal to the terminal bronchiole is very, very important. Okay. So what is the pathogenesis? Pathogenesis, you have like smoking or air pollution, some genetic predisposition, like, and there is another one important disease like congenital alpha-1 antitrypsin deficiency. Okay, we'll come to know what this antitrypsin is. This antitrypsin is a very, very potent anti-protease enzyme. Okay, it prevent the, because the lung is made up of all the protein. Okay, like elastin, different type of, which are among that the elastin is very, very important protein. Okay, and you also have in our body some proteases enzyme. These protease enzyme will destroy the normal elastin of the lungs. So we have been provided a naturally anti-protease, which is alpha-1 antitrypsin. Okay, when there is a deficiency of these alpha-1 antitrypsin, there is protease anti-protease imbalance. less number of antiprotease and high number of the protease. And this will lead to the alveolar wall destruction. Again, when you smoke, smoke will bring the oxidative stress, and this oxidative stress will lead to the apoptosis of the alveolar wall. Again, smoking will bring the inflammatory cells, and these inflammatory cells, mainly the neutrophils, they secrete a large number of protease, and these protease will destroy the protein in the elastic tissue of the lung. And the most important protease over here is the elastase. And this will lead to the alveolar wall destruction. So one is the toxic injury and the inflammation, mainly seen in the cigarette smoking and other environmental pollutants. They damage the respiratory epithelium and cause the inflammation and parenchymal destruction. Protease anti-protease imbalance. One of the cause for the protease anti-protease imbalance is the congenital alpha-1 antitrypsin deficiency. There is also one acquired alpha-1 antitrypsin deficiency, and that is usually seen in the smokers. These smokers have two mechanisms. One, they bring the neutrophils, and these neutrophils will secrete the protease elastase, and this also will lead to the acquired alpha-1 antitrypsin deficiency. So there is a big protease anti-protease imbalance, the high number of protease and the less number of anti-protease. There is also oxidative stress due to smoking or due to environmental pollutant. They lead to the oxidative reactive oxygen species induce alveolar damage and tissue necrosis. And infection also, especially the bacterial and some viral infection, they generally not cause the direct destruction, but they will exacerbate the existing mechanism, because once the infection comes, it will also bring the neutrophils, and these neutrophils along with pre-existing emphysema, they will progress, or they will accelerate the tissue damage over here. Clear?
Yes.
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 Do you think I am going very fast, or are you able to follow me? Is there any problem with
No, it's
the
okay.
understanding of the language?
No, it's okay.
It's okay. Boys,
Everything
yalla
is good.
shabab. Good. Okay, very good. Thank you. So pathogenesis. We have already know what is actually the mechanism. There are the four mechanisms. So the basic thing is the increase in the protease. And what is the important protease is elastase. How does it increases? It can increase either by, because there is congenital alpha-1 antitrypsin deficiency, so imbalance. Alpha-1 antitrypsin is the natural antiprotease, so they are deficient, so there is automatically increase in the proteases. There is the important, very major factor is the tobacco, which will either cause acquired alpha-1 antitrypsin deficiency, or they will bring these cytokines, interleukin 8, tissue necrotic factor, leukotriene B4, and they will, with the help of these cytokines from the tobacco will cause neutrophil to produce more and more amount of elastasis. So this will again lead to the protease anti-protease imbalance, and this protease anti-protease imbalance will lead to the damage at the alveoli. Okay, so now we go to the types of emphysema. Okay, you have, this is your terminal bronchiole, belong this area which is known as the asinus. This is the main region for the emphysema. What are these here? You have the respiratory bronchiole, you have the alveolar duct and the alveolar sac. So this is the place where you see the emphysema. Okay, and what are the different types of emphysema? We have according to the location where it is affected. Okay, so we have, this is your normal asinus. You have the centri asiner, which is in the central location of the asinus. Okay, mainly involving the alveolar duct or respiratory bronchiole. You have another type of emphysema where you have the pan asinus. entire sinus is involved. Or sometimes you have paraseptal. It is along the alveolar septi. So that's why we call it as a paraseptal. Okay. So you have four types of emphysema. Centriasinal. Okay. Here the respiratory bronchioles are affected principally and distal alveoli are spared. And it is more commonly seen in the upper lobe and very specifically associated with the heavy chronic smokers. Okay. And they also have the association of the chronic bronchitis and bronchiolitis. Okay, the centria sinor, it is in the central of the sinor, respiratory bronchiole associated in the smokers, and there will be some features of chronic bronchitis and bronchiolitis. Panasina, name itself, entire sinus is involved. So there has to be some more strong affection. So more strong affection can be seen in the congenital alpha-1 antitrypsin deficiency. Okay, so here ascites, the uniform complete ascites from the respiratory bronchial duct and the alveolar sac, all are the informed. Okay, and it is usually seen in the lower zones and the bases. Okay, so centriasinal upper zone, smoker, and maybe chronic bronchitis will be seen in respiratory bronchial. Entire sinus, alpha-1 antitrypsin deficiency, lower zone, and the bases. Okay, panasinal. Paraseptal, as name shows, it is around the septi and near at the peripheral spaces near the pleura. Okay, and it is when it is like if it is located near the pleura, so it is one of the common cause for the spontaneous pneumothorax. Okay, this type of when if someone having distal acinar or paraseptal uh, emphysema, if they got cough, if they cough very severely, this will rupture because there is already weakening and the destruction of the wall, and this rupture will lead to the passage of air from lung to the pleural cavity, and that is known as pneumothorax. You know it very well, spontaneous pneumothorax. Okay, and it is usually seen in the upper half of the lungs. Irregular usually post infectious. Okay, and it is like irregular scarring and usually can be seen in the postmortem examination or incidental finding during CT scan, and usually associated with the infection, especially tuberculosis. And it's clinically insignificant. These three are the clinically significant, while the paraseptal, you have spontaneous pneumothorax, panasinar, alpha-1 antitrypsin deficiency, centriasinal, respiratory bronchiole, and heavy smokers. Okay. Pathological feature, you have the, because there is dilatation and destruction of the wall, so the alveoli will look, the lungs will look like a sponge, elastic tissue. You will look like with the wide continuous air spaces, dilated alveolar spaces. Okay, and if it is like sometime you might see this bulle on the bleb on the surface of the lung. Okay, what you see, the bullous emphysema with subpleural bulle, and this is the location which is known to cause spontaneous pneumothorax. Okay, and in the microscopy, very easy to identify this. Okay, if you get this slide in your practical, it is so easy to see. Okay, there is abnormal dilatation of the airway spaces, there is destruction of the wall, and no obvious fibrosis. Maybe it is focal or fibrosis is totally absent. Okay, so this is microscopy. This will get revised again in the practical, so we will not discuss much on over here. Okay, what are the complications over here? Because there is obstruction to the airflow, there is destruction of the wall, so it will lead to the pulmonary vascular hypertension, and that in turn lead to the right-sided heart failure. Okay, pneumothorax, especially the paraseptal kind of or distal acinar type of emphysema. And death usually results from respiratory failure leading to acidosis and coma, right-sided heart failure, which is secondary to the pulmonary hypertension. Okay, and sometimes massive collapse of the lung secondary to the pneumothorax. So all are the emergency situation where you get the respiratory acidosis and coma in the patient of emphysema, massive collapse in the secondary pneumothorax. Okay, and right-sided heart failure. Now the second. disease over here, we are going to talk about chronic bronchitis. So what is the definition of chronic bronchitis? It is the clinical, purely clinical definition. So what is the finding over here? Your patient should have a persistent cough with sputum production for 3 months in a year, at least 2 consecutive years. Suppose I come to you and I say, I have cough and sputum production. So you will ask, how many days you have cough? I'll say so many days. I'll keep on getting cough now, here and then and then. So, okay, can collectively you can say like your cough is for more than 3 months in this year? Yes, doctor, my cough is for more than 3 years. And since how many years you are having this? Since this year only. So you will not call it as a chronic bronchitis. But if I say, I'm having this for the 2, 3 years, so you will clearly label me as a chronic bronchitis patient, and then you send me for the different investigations and confirm the diagnosis. Okay. So you have persistent cough, sputum for 3 months in a year and at least for 2 consecutive years. Okay. Clear about the definition?
Yes.
And there is no other identifiable cause. I should not say that I am suffering from lung cancer. I should not say that I am having TB. I should not say that I am having pneumonia. I have been diagnosed pneumonia last month. Nothing like that. I don't have any abnormalities, but only cough, sputum production, and this cough is chronic, persistent. It will be there for 3 months in a year, and I'm suffering for maybe at least for 2 years, continuous year. Okay, should not say I had 3 years back this complaint. I was fine between last 2 years and now again I am having. Again, I will not call it chronic bronchitis. I will investigate and then see to it on follow up the patient to label him chronic bronchitis. Okay. What is the pathogenesis over here? It is bronchitis. Okay. Tis is there means there is inflammation. It is chronic means persistent inflammation. There is sputum protection means there is excessive mucus. Okay. So persistent inflammation, hypertrophy of the gland, and the excess mucus. Okay, so chronic irritation of the bronchi. This comes majority of the time from the tobacco smoking, sometime from the environmental pollutions like silica and other environmental pollutants. Okay, so there is persistent inflammation in the bronchial wall, submucosal glands hypertrophy in the trachea and the bronchi, and mucus hypersecretion. This is the major mechanism or pathogenetic mechanism for the chronic bronchitis. Okay. How does the morphological changes it will be seen in the chronic bronchitis? You have gross and microscopic examination. Gross, you have like there is swollen hyperemic edematous bronchial wall. There is excessive mucinous or secretion or the hypertrophy of the hyperplasia and the hypertrophy of the goblet cells, narrowing of the lumen, and hyperplasia of the submicroscopic or submucosal glands. Okay, so you see the areas of hyperplasia, increased goblet cell, sometime due to smoking, patient will have metaplasia, squamous metaplasia. There is like in the mucosa, you have the edema, vascular congestion, inflammatory cells, especially the chronic inflammatory cells, and some degree of fibrosis. So you have this squamous metaplasia, respiratory bronchial, chronic inflammatory cells, and the submucosal gland hypertrophy. Again, this will get you get the discussion this again in the practical also. Clinical feature, you have persistent productive cough for years. Respiratory function may be affected in late stages where the patient will have dyspnea on exertion, like little bit exercise or little bit day-to-day activity, patient lead to the have the symptoms of dyspnea. So in that case, respiratory function will be affected. Otherwise, it will be like the patient usually have just persistent productive cough for years. And once this disease sets, patient will have hypercapnia, hypoxemia, respiratory failure, cyanosis, and complication may be like right-sided heart failure and metaplasia and dysplasia of the respiratory epithelium, which may lead to development of the squamous cell carcinoma or the bronchogenic carcinoma. Now, the fourth asthma we have already discussed. We go to the fourth disease directly. That is bronchiectasis. Okay, so here you have definition: permanent dilatation of bronchi and bronchioles. It is caused by destruction of the muscle and the elastic tissue resulting from or associated with chronic necrotizing infection. So very important over here is this association, chronic necrotizing infection. There is destruction of the muscle and elastic tissue. Okay, so these are the two. So what happened when a permanent dilatation of bronchi, bronchial wall destruction, and chronic necrotizing infection. And etiology is like vicious cycle between obstruction and infection. There is infection, there is excessive mucus production. These mucus will block the airway. This blockation will cause again bring on infection, again infection, obstruction, infection, obstruction going on till the wall of the bronchiole start getting affected, getting degenerating and necrosis and destruction of the wall. Okay. And after that, once the destruction start, there is fibrosis, and this fibrosis is the cause for the obstruction. This is what the pathogenesis of bronchitis is. This is how they look like honeycomb appearance, like the beehive. Okay, you have this dilated, somewhere thick, somewhere thin, dilated, abnormally tortuous bronchi or air spaces, which is filled with the necrotic material. And what part of the lung is usually affected? Lower lobes. Sometimes it is bilaterally, sometimes it is unilaterally, and there may be like formation of cyst, which is usually filled with the mucopurulent material. And there is like all the mucosa, submucosa, muscle wall, surrounding lung tissue, everything will mucosa will show atrophic, squamous metaplasia, submucosa, inflammatory cells, degeneration, especially the chronic inflammatory cells, destruction of the elastic tissue, which is replaced by the fibrous tissue, and surrounding lung tissue is also destroyed with inflammation and fibrosis. Clinical feature here, patient have the fever, cough, and purulent sputum production. Okay. And this sputum, because of infection, it will be foul smelling, and sometimes destruction of the wall will cause erosion of the blood vessels. So you might get blood in the sputum. And clubbing of finger is another finding associated with the bronchiectasis. Because of the involvement of a vessel wall, patient may have the blood in the stomach, hemoptysis. Sometimes it may be a large vessel get involved, the severe hemoptysis leading to the shock, pulmonary hypertension because of the fibrosis, and that lead to the right-sided heart failure. What is cor pulmonale? Cor pulmonale is right-sided heart failure associated with the lung diseases. Okay. Sometimes there is formation of abscess in the lung parenchyma. Sometimes the infection may spread from uh, lung to the different organ, to the brain, to the in the blood, or it can go to the kidneys, anywhere it can go. Okay. And sometimes it may lead to the development of amyloidosis. Clinical features of COPD. So as you know, there is but when we're talking about COPD, here we mean the emphysema and bronchitis, especially. Okay. So patient usually have hypoxia, cough, persistent cough, and sputum production. Okay. So usually it is a prolonged disease, chronic persistent disease. So patient have fatigue, frequent respiratory tract infection. They use the accessory muscles because they have hypoxia. They need more oxygen, so they need accessory muscle for respiration. There is orthopnea. Orthopnea means dyspnea even at rest. Okay. In the later stage of the disease, your patient may have the right-sided heart failure, which is known as cor pulmonale. The patient will become, especially the emphysema patient, will become very thin in appearance. Chronic bronchitis may gain weight, may become thin, or may remain the same. Symptoms will be wheezing, pursed lung breathing, cough, barrel chest, dyspnea, prolonged expiratory time, okay, increased sputum, digital clubbing. These are all the signs and symptoms of the COPD. How do you diagnose the case of COPD? You know the history is very, very important. First, you can diagnose It's chronic bronchitis. Along with the history, you can come to a conclusion whether it is emphysema, if your patient is a smoker or working in some of the clinical or some environmental hazardous industries. Okay. Physical and clinical examination will be of less important in cases of the mild and the early diseases, but severe and chronic diseases, you might find the barrel chest. Their chest will be like a tube or like a barrel. Okay, barrel is what you know, you must have seen in the English movie where the wooden box in which they keep the wine. Okay, so barrel chest. Accessory muscle use, you see that your patient is using sternocleidomastoid, abdominal muscles very severely to breathe, sometime weight loss, edema. Okay, and you need to do the x-ray, CT scan, pulmonary function test. And pulmonary function test is the very important test to diagnose and to know the prognosis of COPD. So what you look into the pulmonary function test, you get total lung capacity, forced vital capacity, and forced excitatory volume at FE1. Okay, so these are all decrease. Okay, the these two, one is normal. Okay, total lung capacity and forced vital capacity are the normal, or sometimes they may be increased, because especially in case of emphysema where you get the massive dilatation of the air spaces. Okay, while the forced expiratory volume at 1 second, FE1. Okay, this, I'm not going to much detail about this over here. What is this and what is that? You will be taught in the respiratory physiology. Okay, so this is reduced. So very important finding in the chronic obstructive pulmonary diseases is reduce FEV1. Okay, and these two remain normal. So FEV1 to FVC ratio is decreased, and this is the diagnostic feature. Ratio of FEV1 to FVC decreased. Okay, so this is the diagnostic test of, or diagnostic finding in a pulmonary function test, where you find this, you label a patient as a chronic obstructive pulmonary disease. Okay, main line of management, you need to avoid the trigger. So change the profession, stop the smoking. There is obstruction, so we need to dilate the bronchi, so bronchodilators. There is inflammation, so we may need inhaled or systemic steroids, sometime may need. If there is infection, we need to treat them with antibiotics. Okay, if your patient is for the chronic phase, if there is like repeated exacerbation, we can give them vaccination against influenza, because most of the time this viral infection are like exaggerating factor for the COPD. You can then in cases of the long term, along with all this treatment, your patient might require long term oxygen therapy. Okay, so we have the gold criteria for the COPD directive. This gold criteria will be discussed in detail in your case 3 review lecture. But here we see the stage 1, stage 2, stage 3, and stage 4. These are the 4 stages. And how do you get these stages? In all the diseases, FEV1 to FVC ratio will be less than 0.7. Okay, this will be constant. If you get your forced expiratory volume at 1 second is more than and equal to 80%, it is stage 1. Okay, so what you can give your patient, you can ask them to stop smoking, give influenza vaccine, and if they have symptoms, short acting bronchodilator if needed, we can give. Then comes stage 2. Stage 2, you have same FE1 FVC ratio 0.7, because it is the diagnostic criteria. Without this, you will not diagnose as a COPD. So it will remain constant. But FVVN is less than 80, but more than or equal to 50. It is stage 2, where you will have, along with the stage 1 management, you will have sometime you need to give them long acting bronchodilators and send them to the cardiopulmonary rehabilitation, where they can learn breathing exercise and healthy lifestyle. Stage 3, again the FE1 FEC will remain constant, and it will be less than 50 but more than or equal to 30%. Here the role of glucocorticoids, because the inflammation is persistent over here. Okay. So we need inhaled glucocorticoids. Here, if you find FE1 is less than 30%, or you have respiratory failure. Okay. If respiratory failure comes over here also, okay, so you become stage 4. Okay. So if the respiratory failure is there, so it is stage 4. So here you have to give the oxygen therapy, and sometime you need to think for the lung transplantation. This is again the same chart, which is in the graphical way. So this is a very important chart to know how do you stage 1, 2, 3, 4, and what is the management plan. Management plan might change from here to your case review, but majority of the time it will remain like this only.
Doctor,
Yeah,
why write 1 and 2 as stage 1? I don't understand.
1 and 2. This is the number 1, 2. Okay, reduction of the risk factors, short acting bronchodilator, as we see in the stage 1. Along with you have long acting this will remain same in stage 2. Okay, as we go to the stage 3, so you have to reduce the risk factor. You may give short acting or long acting bronchodilators and the cardiac pulmonary rehabilitation, as well as you give the inhaled glucocorticoids. Here you have same like risk factor reduction, short or long acting bronchodilators, cardiopulmonary rehabilitation, inhaled glucocorticoids plus oxygen therapy, and if it is not responding, then go for the surgical treatment. Okay.
Yes, okay.
Mm. Now we go to the other major lung diseases, restrictive disease. As we started 15 minutes late, so our time might increase. So just excuse from the next doctor. Okay. So this is the diffuse interstitial lung diseases or restrictive lung diseases. As you name it, such as interstitial means it is there is involvement of the lung parenchyma, the interstitial spaces of the lung. Okay, not properly the air spaces. Okay, the septa, the supporting structure of the lung, and there is a diffuse involvement. Okay, and this is diffuse involvement of the pulmonary connective tissue. Simple. Okay, definition is like the name itself, diffuse involvement of the interstitium of the lung or pulmonary connective tissue. There are two groups. Okay, one is the fibrosing disease, another one is the granulomatous. Granulomatous is very easy to remember, sarcoidosis. Okay, sarcoidosis is a diffuse interstitial granulomatous lung disease. Okay, where the etiology we don't know, maybe idiopathic or maybe sometime associated with the infection. While you have, and you know other granulomatous diseases also like tuberculosis, leprosy and all, which has been discussed to you with chronic inflammation, but that disease will not come over here. Here specifically sarcoidosis only for the diffuse interstitial lung disease or pulmonary fibrosis. Okay, in the fibrosing diseases you have idiopathic pulmonary fibrosis, non-specific interstitial pneumonia, collagen vascular diseases like autoimmune diseases, as you see in the systemic lupus erythematosus, pneumoconiosis, and sometimes therapy, especially a person who is taking anti-cancer treatment, they may have diffuse interstitial fibrosis of the lung due to chemotherapeutic agents, due to chemotherapeutic drugs like bleomycin or some other drugs. Okay. So what is the pathogenesis of interstitial lung fibrosis? There is different causes, maybe like exposure to the occupational hazard, chemotherapeutic agents, or sarcoidosis. So this will lead to the inflammation and injury to the pneumocytes. Okay, this inflammation will lead to activation of the macrophage and mast cells. Okay, these macrophages and mast cells will produce various cytokines and tissue growth factor alpha. This tissue growth factor, fibroblast growth factor, platelet derived growth factor, epithelial growth factor, and inflammatory site will lead to the fibroblastic and myofibroblastic proliferation in the lung interstitium and leading to the fibrosis, thus restricting the flow or airflow by restricting the dilatation of the sinus. Complication, this is not come immediately. It is a slow, a long standing process, may take years. Okay, so there is gradual increasing dyspnea and dry cough. Okay, cough is specifically dry over here. Okay, there is no productive cough over here. Okay, gradual deterioration of the pulmonary function, hypoxia or hypoxemia, right-sided heart failure, cor pulmonale, and the only treatment because here the interstitium is affected, so bronchodilators, steroids, or antibiotics will not have much role over here. Okay, the definitive treatment is only you have the lung transplantation for these. Okay, so we go to the one of the commonest cause, the environmental hazard leading to the this diffuse interstitial fibrosis or diffuse interstitial lung diseases. Okay, so this is what do you know by pneumoconiosis? This is inhalation of the certain organic or inorganic particles from the environment. Like coal dust, coal is very common, silica, asbestos, berylliosis. Okay, and these particles get entrapped inside the lung parenchyma. They will induce macrophages. These macrophages will produce cytokines, and that initiates fibroblast proliferation and collagen deposition, thus leading to the interstitial fibrosis. We have already discussed the complications over here, like progressive dyspnea, chronic heart failure, cor pulmonale, and eventually death. Okay, and there is also an increased risk of bronchogenic carcinoma and mesothelioma, especially related with the asbestos. This blue color, if someone is exposed to the asbestos, they develop the asbestosis or the pneumoconiosis, there is very high increased risk of either bronchogenic carcinoma or malignant tumor of the pleura, which is known as mesothelioma. These are all the lung diseases, and this is the particle, this is the disease, and where they get exposed. Like coal dust, you get coal mining, and what you call anthracosis, progressive massive fibrosis, Kaplan syndrome, silica, silicosis, Kaplan syndrome. There is a homework for you. We need to find out what is Kaplan syndrome. Okay, because it is there in Kaplan syndrome, is there in all these pneumoconiosis. Okay, so this is a homework, and send me a WhatsApp message about definition of Kaplan syndrome. Okay, so this table, at least read this: coal dust, silica, asbestos, beryllium. Okay, and sometimes this is like this type of this thing. These are the organic dust, usually like with the farmers. Okay, or working in the organic industries. They causes hypersensitivity, pneumonitis, and fibrosis. So hypersensitive pneumonitis is usually seen in the farmer slum, bagasosis, or bird dropping. Okay, if you someone stays with lot of birds, like with pigeons or parrots, so you have the bird breeder's lung or bird handling. Now we go to the coal workers pneumoconiosis. It is the common type caused by inhalation of the coal dust particles, especially in the coal miners or the one who reside near to the coal mines. Okay, they have two types of manifestation. Okay, one is the simple coal workers pneumoconiosis, or the second one is the progressive massive fibrosis. While anthracosis is not a pneumoconiosis, anthracosis is just carbon particles coming from cigarette, automobile exhaust. Okay, and this anthracotic pigments is deposited into the alveolar macrophages and lymph nodes. Okay, there is no respiratory effect. When you call anthracosis, it is just carbon pigmentation in the alveolar macrophages and the tracheal or hilar lymph nodes. Okay, it does not cause any disease per se, but simple coal workers pneumoconiosis and progressive massive fibrosis are a disease manifestation of the coal particles. Silicosis, it is chronic disease, formation of silicon nodules. Okay, there is formation of nodules of silicon in the lungs. Okay, and why it happens? Because of the prolonged inhalation of silicon dioxide. Okay, and when it happens, usually those who work in the granite mine, construction industries, sandstone, copper, and tin, ceramic worker, pottery, okay, pencil preparation, okay. All these people are exposed to the silica. They are small particle, 0.5 to 5 millimeter. They go to the alveoli, get taken up by the alveolar macrophages. These alveolar macrophages get activated by this particle. They can either lead to the phagocytosis or necrosis of the macrophages. And these silica-laden macrophages then go to the respiratory bronchiole, alveoli, interstitial tissue, and the lymph node, where they bring about the inflammatory response and fibroblasts like growth factor, deposition of fibrosis and collagen. The second important pneumoconiosis or environmental disease is asbestosis. Okay. It is caused by asbestos fiber. Okay, it causes three type of diseases. Okay, asbestosis of the lung, pleural diseases, and tumors. Those two tumors, bronchogenic carcinoma, and the one is very specific is mesothelioma. Pathogenesis remain the same. The role of macrophage is very, very important over here. Okay, so we know about the obstructive diseases. We know about the restrictive diseases. How do you differentiate between them? Okay. It is characterized, obstructive is characterized by the limitation of the airflow, either due to partial or complete obstruction. It is, there is restriction. So there is reduced expansion of the lung parenchyma accompanied by decreased total lung capacity. Okay. So decreased total because there is fibrosis. So lung cannot expand properly. So there is decreased total lung capacity. Example over here are chronic bronchitis, emphysema, bronchiectasis, bronchial asthma. Here you have like fibrosing alveolitis, interstitial lung disease, idiopathic pulmonary fibrosis, pneumoconiosis, farmer's lung. Okay. Here, total lung capacity is normal. Here, total lung capacity is decreased. Forced vital capacity is normal. It is reduced. Okay. FE1 is always reduced over here. Okay. It is either normal or reduced. FE1 FVC ratio less than 0.8 or less than 0.7, where it is normal. Why it is normal? Because the both the total lung capacity is reduced, but FE1 will be normal. Okay, so that's why FV1 and FVC ratio will be normal, not going to reduce. Okay, when it is normal and it is reduced, so upper thing is normal. Okay, so it will remain normal, but here both are reduced. So that's why it is reduced. And especially, I'm sorry, it's FVC is normal over here and FEV1 is reduced. So when the denominator is, you have that FVE1 and FVC ratio. So when it is reduced, definitely the ratio will going to be reduced. While here it is normal, so ratio will remain normal. Okay, so this is the very, very important differentiating feature over here. This ratio is reduced over here and the ratio is normal over here. So this is how we do the division of obstructive and restrictive lung diseases. This is our reference, Robbins 10th edition. Okay, for both the pathologies, okay, obstructive and the restrictive lung diseases. I hope it is clear for you all.
Doctor, I have a question.
Yes, please.
In this slide, how normal ratio of FEV and FVC?
Because you know, here you have the FEV1. Suppose we take an example, okay? FEV1 is, you take normal FEV1 is 10, okay? And FEVC is 20. This is the normal. So 10 upon 20 is become 0.5. This is the normal. Okay, 0.5. Okay. Now we take FEVC. We have 20. Okay. So FEVC is reduced over here. So we take it like here it is reduced. We take 10. Okay. But FEE1, okay, which is 10. So 10 divided by 10, it will become 1. Okay. So it remain normal. It will not reduce. It is always reduced because why it is reduced? FE1 is very, very strongly decreased in the obstructive diseases, but that is not reduced over here. Okay. And this remain normal in obstructive diseases, and in the restrictive diseases, forced vital capacity is reduced. Okay. You need to have little bit mathematics over here. So once you take this chart and do the mathematics, you will, inshallah, you will understand that. Why, see, this is normal, this is reduced. So when this is reduced, that upper part is reduced, okay? FE1 is reduced when the forced vital capacity is normal, okay? And this is reduced. Obviously, the ratio is going to be reduced, okay? But when the upper one is normal and the lower part is reduced, so either it is increased or normal. It will not be as reduced, which you see in the FE1 FEC ratio. It is always to diagnose the obstructive disease, you have to have FE1 FEC ratio. Previously it was 0.8, now they say it's less than 0.7. Okay, if it become reduced over here, this will become obstructive. It is not restrictive disease. Is it clear? I don't think so. It will, because it is little bit confusing. It need to be a like it need to be a like the in-person class where we can learn with the chalk and board. That in that case it will be easy to understand. But just to remain your mind, FVC is normal. It is reduced. Okay, and FV1 is like severely reduced. Okay. And here it remain normal or sometime it is reduced, but when it is reduced, this is also reduced. Okay, so you will not get the ratio less than this. If the ratio is less than this, it will be obstructive only. It cannot be restrictive. In the restrictive, if the normal value is 1, it will always come 1. We take as a 1 as a normal value. Okay, so it will always remain 1, and here it is always less than 0.8 or 0.7. Okay, another example I take, we take everything 10, FVC 10 and FEV1 10. Okay, this is, you see, normal value. Okay, so your ratio is 1. This is normal ratio. Okay, now you take FVC remain normal, so that is 10 only. But FEVN in the obstructive disease has become, say for example, it is 7. So 7 divided by 10, it become 0.7. Okay. Now come to the restrictive diseases. Okay. Here we have forced vital capacity is reduced. It is become, now we take it 7. But your FVEC is normal 10. Okay. So 10 divided by 7. So it will become 1 point something, 1.4 or something like that. Okay, so either it is normal or increase, but here it will always be reduced. I hope so. I have made it easy for you, but I think for this you need to have a chalk and board. Like really, I cannot, like or inshallah I will make a normal, like we'll make a table, normal values, and then I'll do it on, send a screenshot for you. Okay.
Yes, thank you. Doctor?
Any other questions?
Doctor,
Yeah.
I have a question.
Yes, please.
diffuse interstitial lung disease. It's beginning in the lung and then expands to interstitial, right? Or the first
No,
interstitial.
yeah. It is like, like the particles, the like inhaled particles come into the airspace. Okay, there they have been taken with the macrophages, and these macrophages will go into the interstitium, and then there they will work. Okay, or the macrophage will come from circulation to the lung to kill this inhaled particles, but it will not be able to kill them. It get activated, and then it will, with the help of interleukins and tissue growth factor, it will bring the fibroblasts and deposition of the collagen inside the parenchyma, not in the alveoli. Okay.
Mean in the beginning in the interstitial.
No, it doesn't big, like it always affect the interstitium. Okay. The particles will not go directly into the interstitium. They will come into the airspace, a sinus, okay? From there, with the help of macrophage, because macrophage will come to clear these foreign particles, isn't it?
Yes.
Normal phagocytosis, the macrophages will come in role, alveolar macrophages get activated. They will take this part, okay? The inflammatory process begin in the alveoli, but affect the interstitium, does not affect the alveoli, okay? Whatever the deposition of the fibrous collagen will happen in the interstitium. In a way, you are correct. It begins in the alveoli, begins in the airspace and affect the interstitium.
Yes. Thank you, doctor.
Clear or not?
Yes, doctor, clear. Thank you.
Okay, welcome. Any other questions? Boys, where are my
Doctor, I
boys?
have a question.
Yeah,
Emphysema, it's a dilatation of the alveoli sac. So
yes,
it's why it's a obstruction pulmonary disease,
obstruction.
not dilatation.
Yes,
Yes.
correct question. Okay, now come back to emphysema slide. Okay. So why the obstruction in the emphysema? Okay. This obstruction comes from where there is destruction of the sac, okay, without much fibrosis, okay. So what happened over here? One second, I explained once I get the slide. So this is not the proper obstruction, like there is no thickening of the wall, there is no narrowing of the lumen. There is functional airflow obstruction, okay? Why there is a functional airflow obstruction? If you see this microscopic slide, okay? The air or this schematic diagram, okay? So air should come from here, okay? This, it should come from here, and go to equally to each and every asinus, okay? But there is destruction of the asinus, okay? There is no free flow of the air in this asinus because there is destruction of the wall. There is destruction of the normal anatomy. So when there is a normal, if you take a pipe, okay, suppose you have taken a pipe, you flow the water from there, okay? And you measure the water, it fill a bucket in suppose 10 minutes, or it just there is a uniform flow of the water, but you damage the pipe from here and there, okay? The flow will be not as same as what you see in the normal pipe. Same over here. So this is not the what you call it. It's not the pathological obstruction. It is a functional obstruction. Functional obstruction means there is no free flow of the air because of the destruction of the parenchyma. So there is a functional airflow obstruction. And these functional airflow, as you can see over here also. So there is no free flow. There is destruction of the alveoli. There's some alveoli are getting more air, some alveoli are getting less air. That's why you get obstruction to the airflow. And because this is the functional obstruction, you read about the clinical in the clinical book like Harrison or McLeod's, you will find these patient of emphysema. They will have, they will not have cyanosis. They will have, instead they will look as a pink. That's why we call them emphysema patient as a pink puffers. While the chronic bronchitis patient, we call them as a blue bloaters. So this is a functional obstruction. The oxygenation is more or less remain same. Yes,
Okay, doctor, thank you.
welcome. So I will not, we have already taken 20 minutes. I think someone must be waiting behind us. So I will stop over here. Okay. If you have questions, send me on my personal WhatsApp. Okay. Thank you.